I can't believe it. Again, I met a potential client here at the coffee shop, and they ended up going with someone else. Said they wanted to work with someone who looked more established.
Oh no, that's unfortunate, but honestly, why are you still meeting clients at coffee shops? You should check out J. Kenba Executive Suites.
J. Kenba? Never heard of it.
Really? It's a professional office space right here in Baton Rouge. You can rent an office that's already furnished, plus they include Wi-Fi, secure building access, utilities, on-site parking, and they even handle the regular cleaning. All you have to do is show up and focus on your clients.
Wait, they handle the cleaning too? That sounds way easier than trying to make my home office look professional or hunting for a quiet spot at a coffee shop.
Exactly. And if you don't need a full-time office, they even rent out conference rooms for small meetings and workshops. Perfect for impressing clients without the overhead.
That's exactly what I need. Where do I find out more information?
Just visit jkenba.com and schedule a tour. Trust me, you'll wonder why you didn't do this sooner.
J. Kenba Executive Suites. We provide the professional space. You create the success. Visit jkenba.com today.
Welcome to the Byja Radio Show. I'm your host, Dr. Byron Jasper, and we are recording live from J. Kenba Executive Suites in Baton Rouge, Louisiana, with special production by Becnel Media. Coming back like 4 flats on a Cadillac. I mean, what more can you say? You got Byja Radio, so your day must be going amazing. And I say that with confidence because, as I've said several times before, you could have been anywhere in the world, but you're here with us.
Yes,
and
sir.
when I say us, that must mean I'm sitting next to the host with the most, who literally doesn't sweat at all because he's just a nice, cold brother.
Yes, sir.
The one and only Patient Zero. How are you feeling today, my brother?
Brother, I'm great. I'm happy to be here, man. I'm just happy we hadn't got canceled yet. You know, it's always a win. So how you doing today?
I'm doing great, man. And I'm going to tell you why. Because, again, people don't realize that the way I have such a sunny disposition is I always set the bar extremely low. Why? Because pretty good to get small victories.
Yeah.
Enough small victories give you enough momentum. All of a sudden, you're doing a lot. So, like you, basically not getting canceled is a small victory.
Hey,
so
man.
I'm all about that. So I'm all about stacking these small wins, and eventually they turn to big wins. Right?
I tell you what, man, like in my career, when I learned how to under promise and over deliver,
Right. There you go.
that made all the difference.
There you go. And I feel like by doing Byja Radio, people don't realize that we're not necessarily trying to, in essence, eliminate all need for all healthcare everywhere. I mean, eventually we're going to get there. That's the confidence I have. But to start, all we're doing is trying to put out good content. And the content literally is for people to say, man, I learned something from your episode or episodes, because we have some avid listeners who are honestly some amazing people, because they'll come to us and tell us stuff that they learned or heard and things that help them get better. And of course, what does that come from? A lot of times it comes from different topics that are brought to us or things that just show up in everyday life. So most people already know kind of where we're going because, of course, when they look at the episode title, they'll know. But we always say, hey, these things come up all the time between conversations with me and my patients, but also sometimes conversations between you and I. And one of the things that most recently popped up was conversation about prostate stuff, prostate health specifically. And we've done an episode on testicular health, but not necessarily prostate, right? So people might think they're one and the same, but they're not. Different anatomy, different locations, and we'll talk about that a little bit. But the idea is that with prostate health, if you are not really and truthfully familiar with it, getting it checked and being very intentional about it, it's going to cause problems that sneak up on you. So of course, with the prostate health, it's important for mostly every male to have some sense of this information on some level, and then hopefully get into care to get it checked and have it checked regularly. And with that being said, I'm going to turn to patient zero and ask a question that I think is a fair question. How many times prior to you being in medical care with the primary care doctor did you ever talk to anyone about prostate health?
Yeah, that's not a conversation I'd like to have.
Well, again, I'd like to. I didn't say you were excited, but did anyone ever say, hey, these are things you should know about prostate health? one way, shape, or form. And again, doesn't have to be very detailed, but just, hey, man, when you get to this age, this is when you should start doing this. Anybody ever just generally, because again, why am I saying that? Breast cancer, colon cancer, like people tend to talk about those, right?
Right.
But prostate is kind of it's on an island somewhere in the Bermuda Triangle. You don't really hear about it until randomly something happens.
So me personally, my uncle had prostate cancer a few years ago and he beat it.
Okay.
And that's kind of what made me aware of it, honestly.
Yeah.
Also, with the 100 Black Men, we did a prostate screening at the 100 office a few years ago.
Good.
So that kind of those couple of things made me more aware of prostate health. Okay. And what you should do, and that's something that I seriously have to think about, being I just hit 40. Mm-hmm. So that's something that I need to take very, very seriously.
Yeah. Now, you answered some of the question, but I want to be specific. So in personal conversation, not necessarily in professional settings or settings where you're in an organization, conversation doesn't tend to come up a lot.
No,
right?
it doesn't. And I think, and I'm going to add one more conversation. I had a mentor of mine, and we were helping him move some stuff. And I saw some horny goat weed supplements in his, in the box. So, me being the guy I am, of course I'm gonna make a joke about it.
Yep.
Because, like the material's there. It's horny goat weed. It's just there for you, right?
This joke writes itself.
It writes itself. I didn't even have to say anything. But so apparently, he had a history of prostate cancer in his family, and he was just trying to be on top of it and take those things to make sure that he had a healthy prostate. Mm-hmm. And that was the first time I had ever heard that.
Gotcha. Well, I think that kind of sums up why I think doing this episode is important. I've been on other podcasts, other men's health panels and things like that, and it is something that often gets talked about in those settings, but it's never really a general conversation. So my hope is that after today's episode, whoever's listening, they will come through and say, man, I learned a lot more about it to where I feel comfortable having this conversation. It may not have to be all detailed and graphic, but it gives me enough of a foundation to know when the conversation needs to start, who needs to have more of the conversation than who doesn't, but more importantly, not be as taboo about it, if that makes sense. Okay. So like we always do, we're going to start off with our very, very high level and then kind of go into the weeds. So high level, we always start with statistics, right? George, why do we like numbers?
Because numbers don't have an opinion. So there's no feelings.
Right. So there are no real conversational pieces around numbers other than for us just sharing the details and the stats with you, because we want you to know that the things we're talking about aren't just being pulled out of thin air. A lot of times it's being pulled because something happened with the patient that we saw, or it's in the news, or it's somebody who asked us to have a conversation. So when we talk about these statistics, I think it'll bring home why this is an important conversation. It's not just because of what happened most recently with the former president. That is important, and it does highlight some things. Sure. But it's important because some of these numbers will possibly wake people up to say this isn't something that's very small and taboo and in a very, very, very select few. This is pretty rampant, okay? So patient zero, if you don't mind, why don't you give us some of the stats that you have in terms of prevalence, and then, of course, we'll go into who's more at risk versus who's not.
Sure. So with the exception of skin cancer, which is pretty interesting, by the way, with the exception of skin cancer, prostate cancer is the most commonly diagnosed cancer among men in the United States. It's projected that about 313,000 new cases will be diagnosed, with about 36,000 deaths attributed to the disease. So that's over a tenth of, the people who are diagnosed with it will die of it. That's a lot, right? Yeah. Lifetime risk: 1 in 8 men will be diagnosed with prostate cancer during their lifetime.
Yep.
So, we'll have a Brothers Bourbon in business event, and we have more than 8 people. At least one of those brothers will probably be diagnosed with prostate cancer. That's a lot to take in.
Yep.
12.5% of people. that's a huge number, right? Age-related risks. Under 50, rare, accounting for less than 1% of cases. 50 to 64 years, about 30% of new cases occur in this group. 65 to 74 group represents the highest incidence, with 42.9%. 75 to 84 accounts for 17%, and 85 and older accounts for about 4%. The median age at diagnosis is 68 years. The median age of death is 79 years.
All right. So we'll pause there for a second. So there's a lot to unpack there, okay?
Sure.
So you said 1 in 8 is probably going to be diagnosed with prostate cancer.
Correct.
And then you went into the different tiers in terms of age ranges that are more at risk versus less at risk. And the one that I think we would highlight is if you're between the ages of 65 and 74, it potentially is the highest risk age range at 42%, 42.9% to be specific. Then 50 to 64 is 29.4%. So basically anywhere from 50 to 75, right? You're making up the majority of the people who are getting diagnosed. And that's important.
About 95%, right.
Right. And that's important because what tends to happen with a lot of people is they say, and my favorite quote or favorite response or favorite statement from patients is, well, I didn't think it could happen to me. And that often is something because they really don't know prevalence. They don't know stats. They don't know epidemiology. They're not supposed to know all of that because that's not what you're trained on. That's not what you're taught to know. But when we tell you that, hey, if you're in your 50s, potentially all the way up to 75, this should be something you're talking about regularly. And when I say regularly, not regularly with your healthcare professional, regularly like, hey man, I got mine checked. I'm not saying you need to go and do this and I need to be all graphic, but make sure you're doing the same. You get what I'm saying? Not taboo. It doesn't have to be, well, let me tell you how it got checked. No, I'm not saying any of that. I didn't even say you need to talk about your numbers, which we'll talk about. But if you just say by 50 to 75, you are at risk more than anybody else just on age alone. We ain't talking about the other risk factors yet. From that age range, if you're having conversations with your brothers, your uncles, your cousins, and you're literally starting to have those conversations regularly, then that can be reassuring that, hey man, we got it checked. We didn't wait until we started having symptoms, and then that's when we identify the cancer or the diagnosis. Then you're going to potentially have an issue, right? And again, we're specifically talking about prostate cancer. We're not talking about all the other prostate disease, because what happens is there are other symptoms and other diagnoses of the prostate that aren't cancer that can also cause problems. But when we're talking about cancer, for the most part, we're talking about the 50 to 75-year-olds. That's pretty much what we're getting at, okay? I like to highlight that because it's not saying that you should wait till 50 to start the screening. It's saying that those are the people who have the most prevalence just on age alone, okay? So we'll move forward, and I want to go into racial demographics and ethnic demographics. So patient zero, what you got for us?
So, spoiler alert. Last episode, I was like excited that black people didn't have the worst numbers.
I remember.
Let's just say I'm not excited.
Very short-lived is what you said.
Oh man, I had a week.
Well, let's do the opposite. Let's, instead of going with the highest, let's go from the lowest and then go in reverse. Okay.
Sure.
Who is the lowest in terms of the breakdown in males from a racial standpoint based on the numbers we have?
So, looking at this, the non-Hispanic, Asian, Pacific Islander men, they have about 51 cases per 100,000.
Okay.
That's really low.
Okay.
Then you have non-Hispanic, American, Indian, Alaska Native men that are about 79 per 100,000.
Okay. So again, non-Hispanic, Asian, Pacific Islanders, right? That is 51.2 per 100,000.
Right. So I'm sorry, and not to cut you off, the mortality rate of the non-Hispanic, Asian, Pacific Islander men is 8.8 per 100,000.
Okay. So I wanted to say that to set the idea of where we're going. Okay?
Right.
So we're at 51.2 per 100,000 for the incidence rate. Mortality rate is 8.8 in that same 100,000.
Correct.
Okay. We go into American Indian and Alaska Natives. So that jumped from 51 to 79.3 per 100,000.
And the mortality rate essentially doubled.
Okay.
Right. You're looking at 18.9.
Okay.
So 19 really
Gotcha.
out of 100,000.
Okay. So that gives us the bottom two. Let's keep going. What's the next one you got?
So Hispanic men have about 104 per 100,000 on the incidence, but the mortality rate is a little lower than non-Hispanic American Indian, Alaskan Native men. So you're looking at about 15 per 100,000.
Okay.
Right.
So let me, again, I'm summarizing because I'm hoping it builds up enough for people to see what we call disparities. Okay.
Yep.
So again, real quickly, for the Pacific Islanders, Asian men, mortality rate is 8.8. For American Indian, Alaska Native men, 18.9. For Hispanic males, 15.4. This is mortality.
Per 100,000.
Per 100,000, okay? So again, 8.8, 18.9, 15.4. So if we put them in order, the Asian males have the lowest mortality, followed by Hispanic males, followed by American Indian males, okay? That's the bottom three, okay? So we got two more.
So this is also very, very interesting, right? Non-Hispanic white men,
Okay.
right? You got about 187 per 100,000 on the incidence.
Yep.
So they almost double everybody else,
Okay.
right? But the mortality rate is 18. So the mortality rate is slightly less than the non-Hispanic Indian Alaska Native men, even though they have a little over double the incidence.
Yes. Yep. So 186 per 100,000 with a mortality rate of 18.4 per 100,000 compared to your non-Hispanic American Indian Alaska Native men. They have a incidence rate of 79.3 per 100,000, but their mortality rate is 18.9. So way more people getting diagnosed that are white males, but a lot less are dying versus a lot less are getting diagnosed and a lot more are dying when it comes to the American Indian, Alaska Native men.
Yeah, so that's clearly a access to care and variety of care
Yep.
issue.
Okay. Now, the moment that you've all been waiting for, and if you see patient zero's face and the amount of disgust, you should take pride in knowing that that week was very short-lived.
So you remember that Dave Chappelle skit when he did the racial draft?
Yes.
And Most Def's character made a deal. I think it was Eminem for O.J. Simpson or something like that. You remember that?
I do remember.
And you remember the disgust on Dave Chappelle's face?
Yes.
That's, if you can picture that, that's what I look like right now.
Disgust you have right now? Okay. So let's
So-
tell the people why you have the disgust.
So non-Hispanic black men,
Okay.
the incidence is over 202 per 100,000.
Okay.
The mortality rate is 37 per 100,000.
Okay.
So that's double the next highest group.
Okay. Funniest thing is if you literally do some math, if you add in the mortality rate of white men and the mortality rate of the American Indian Alaska Natives, you combine them, they still have lower mortality than black men.
That's wild.
The second and third group for mortality combined have less mortality from prostate cancer than black males. And again, we are more affected in an incidence standpoint. So I'm bringing that to hopefully our listeners' attention because this is what you call a healthcare disparity, a disparity that these people get diagnosed at a higher rate and die at a higher rate than any other group. But then when you combine these other groups, they're still dying at a higher rate. That goes to show you how drastically different care may be, access to care may be, ability to understand when you should get into care, knowing about the diagnosis, knowing about the symptoms, all the things that we're hopefully going to cover, it really and truthfully highlights how drastic these disparities are. And this mortality stuff is not actually a huge difference from other things we've talked about. That's why patient zero is sitting here saying it is very short-lived that Black people are often not at the top of the list when it comes to negative things in healthcare. And that's only, in my opinion, because, well, I'm not going to say only, that's mostly because what we're dealing with is a lot of patients not having access to care or the understanding of when care should be delivered or sought after. So we're trying to change that. And if we can change that, my hope is that we'll get more people who go from this episode to say, I'm in these categories, I am 50, 55, and I'm an African-American male. I haven't ever had this conversation with anybody. I probably need to find out what's going on. Or, hey, I am a Hispanic male. I haven't had this this discussion about this topic with anybody. I need to get checked and know more about it.
True.
Now, some people may be great. Hey, I do this all the time. I get checked all the time. I never have to really flinch about it. No problem at all. Great. I'm happy for them. But the ones that are not, have not, and more than likely will not unless they're listening to us, that tells us we're doing something to help people hopefully change not only their lives, but to sustain life. Right?
Yeah.
And I can say with confidence, I had a visit with one of our patients yesterday. And again, no crazy risk factors other than some stuff we're going to talk about. But it was definitely did we check your numbers for your prostate already? And I literally said, let me go back and check, because I was talking to him, but I was talking out loud saying, I think we did, but let me be sure. And I was happy to see that we had already checked it. So that gave me a peace of mind that he's good, and we've already done our due diligence well before he turned 50. But we are doing it because we know that risk factors are present. And if they're present, the screening is going to be probably a little bit sooner than waiting until you're 50, if you will. Okay? So with that, we're going to talk about symptoms, but we're going to talk about the symptoms when we come back.
Hi, it's Patient Zero from the Byja Radio Show. Are you tired of the broken healthcare system? Frustrated by long waits, rushed visits, and sky-high costs? Yeah, I was too. So if you're tired of dealing with any of those things, then I highly suggest you check out the book Byja Blueprint, an introductory guide to direct primary care written by our own Dr. Byron Jasper. It breaks down all you need to know about direct primary care, a model that makes healthcare simple, affordable, and personal again. The book covers topics like how DPC differs from traditional insurance-based care, what's the difference between direct primary care and concierge medicine, how employers can use DPC to cut healthcare costs, how this model reduces burnout and improves work-life balance for physicians, and so much more. Whether you're a patient like me, a doctor fed up with burnout, or a business owner tired of rising healthcare costs, this book lays it all out in plain English. If you're ready for something better, check out Byja Blueprint, available in paperback, audio, and ebook format. Visit bookstoread.com/Byja Blueprint DPC and get your copy today.
Coming back in, man, and I'm happy to say we're doing great, man. We got commercials and sponsors, and I'm like, okay, well, go ahead and run us these advertising dollars, people.
Yeah, man,
we appreciate that.
Put a little gas in my truck.
There you go. There you go. So again, if you'd like to sponsor your business and talk more about things that you offer, Byja Radio is not above taking on those advertisements. Why? Because we want to actually help promote business, but we also want to make sure that people are getting good service. So with that, definitely want to give Patient Zero a thumbs up for doing his thing and making sure these commercials not only are acquired, but also putting them out there to where they sound and are basically done in an amazing manner. So kudos to you, brother. I appreciate you.
Appreciate that, bro.
So we're going to circle into what we were kind of going into before the actual commercial break, and that was symptoms, right?
Right.
So we talked about the age ranges. Mm-hmm. We talked about the stats that it's very, very prevalent, that a lot of people are getting this. 1 in 8 are getting it, not 1 in 800, 1 in 8, right? So again, as Patient Zero would put out, if you got, 8 people in the room, one of them is going to have cancer. That's literally something that's pretty significant, not 1 in 800 or 1 in 8,000. So it's very prevalent when you hear 1 in 8.
Yeah.
Right? So going one step further, we're going to talk about, well, what would make you think, man, I need to potentially be screened for prostate cancer other than just how old I am and that I'm a male and I'm in a certain racial demographic. So symptoms are a big part of that. You were going to say something, patient zero?
No, I was just saying that, in addition to, to kind of tap on the racial demographic, if I'm listening to this and I'm and I'm one of the Asian Pacific Islander brothers, and it's 50 per 100,000, I'm in my 40s, it might not be alarming, right? But as a black man, that is tripled.
Yeah, easily.
So before I hit the 50 range, I might be a little concerned. And that's even before I even get to the symptoms, because a lot of times once you get to the symptoms, it's progressed a little bit to where it makes it harder to treat.
Yep. And you wonder why a lot of our patients, well, I'm not going to say you, but a lot of our patients are wondering why I screen them and they're in their 40s. And they're wondering why, well, I'm getting screened and no one else is getting screened. Well, number one, you're in a higher category in terms of incidence and a higher category in terms of mortality. So I'm going to be a little bit more aggressive in my screening because I want to catch it early. And if I catch things early, it's more likely to be treated successfully rather than spreading and having problems. So that's a part of the idea of how to screen and when to screen, again, which we're going to talk about, but that highlights the point. Like you said, you have 50 per 100,000 versus 200 per 100,000. So you have tripled, if not quadrupled, how many the incidents are going to be. So yeah,
and
I'm
the
going to screen
mortality
more.
rate is tripled.
And I'm going to screen more frequently and more aggressively than other people because I know that the people that we're serving, if they happen to be black males, need to be screened a little bit differently than the white males or the Hispanic males. And believe it or not, all of those demographics you just ran out, I have all of them in our clinic.
Yep.
And we definitely screen all of them, but we screen a little bit differently depending on certain risk factors, right? And again, the main thing that we've talked about is just basic stuff that you can't really, for lack of a better term, control. But symptoms may not be things you can control, but you can definitely identify, right?
Absolutely.
So how do we identify some of the symptoms? So I'll go through these since patient zero usually does the stats. So as far as symptoms go, a lot of these are going to probably sound really basic and really straightforward, but a lot of them are often overlooked. And they're overlooked for one specific reason. People tend to say, I have a symptom, and they happen to think it's normal or it's just going to fix itself and never really want to talk more about them in detail. So what am I talking about symptom-wise? So frequent urination, especially in the middle of the night. Frequent urination, especially in the middle of the night. The medical term for that, we call it as nocturia, like nocturnal, urea for urine, right? So if you're getting up in the middle of the night, you're urinating frequently, that is a huge symptom and a huge red flag. The second thing is difficulty starting and stopping your urinary stream. So when you hear people who go to the bathroom to urinate, on the male side, of course, and when they're urinating, they're standing at the urinal or the toilet for a very long time. And it's nothing happening, and there's nothing happening, and there's nothing happening. That's not normal. That is a problem. And then when you get started, it's hard to stop the stream. It's hard to stop because it's either extremely uncomfortable or you just say, look, I can't do it. It's going to take a while. Now that I've started, it's going to take a while for me to finish. If that's happening, that is a problem. That is a red flag. So that's 2 red flags that tend to get missed and or ignored. Hey, man, I'm getting older, so, it just don't work like it used to. And then they just assume as I'm getting older, that's normal. It's not. Okay? Hey, man, I do have to get up and go to the bathroom more frequently in the middle of the night. That's normal because I'm older. Or my favorite, man, I do drink a lot of water. I'm not saying you don't. But why not be sure rather than just assume?
Right.
So that's 2. We got 3 more that I'm going to run off, and then I'm going to let patient zero add his thoughts. So we talked about, again, difficulty starting and stopping your stream, frequent urination. The other one is, of course, blood in the urine. Blood in the urine is a huge red flag. Now, it could be other stuff, but if you're having blood in the urine, that is something of concern that needs to be checked. Other things are discomfort when you're urinating. So if you're having discomfort, not always burning, but discomfort when you urinate, that could be a problem. And then, of course, just having a weak urinary stream. Now, those are the 5 that are pretty common. Now, my favorite, and the favorite I'm saying that I'm being facetious, The one that I often hear, and if people ignore it, they don't get treated and or evaluated appropriately, and it literally gets attributed to something else, and this thing gets missed. I'm going to give you a hint. It's 2 words, and there's a bunch of commercials out about it.
Oh, okay.
Okay? What do you think the 2 words are in medical terms?
Erectile dysfunction.
Erectile dysfunction. That is the red flag of all red flags that should be evaluated in a different way than just my favorite. Can I get a prescription? Because it's easy to give you a prescription for erectile issues than to check and be sure that your erectile issues are caused by something else, meaning you have a secondary cause of erectile dysfunction. It's not a primary cause, secondary. So if you have a cancer that's causing a problem and you literally just take medicine for erections, that's going to be a problem because guess what? Eventually that's going to stop working too, and then the cancer has spread. So erectile dysfunction should not be overlooked as a actual, hey, what else could it be? I actually have diagnosed people's prostate cancer because they had erectile dysfunction. Yeah. And I was able to say, hey, let's talk about this and not just give you a prescription. Because one patient came, and I always love telling this story, not because it's a great story, but to me, I always will remember. Black male came and sat in my office. Literally came from a different doctor's office. He had switched over to me. And this is back when I was in the insurance-based system. Switched over to me, literally saw him and said, what brings you in? Literally came for blood pressure and everything else. So we finished talking about everything else. And long story short, he said, oh, can I get a refill on my erectile medicine? It was Viagra at the time. Mm-hmm. I said, well, why are you taking Viagra? Oh, I'm having erectile issues, blah, blah, blah. I said, well, let's talk a little bit more about it. So we talk about it, and I literally do all the stuff that I normally do because that's just how I am, very detail-oriented. Come to find out the guy had prostate cancer that was not small. It did not spread. We caught it right at that visit because I did the screening the way we were supposed to. He went on to get treated and was able to live another 30 years. Because
that's awesome.
Because we literally said, again, I need a refill because I'm switching over to you. My other doctor had prescribed it, and I just need a refill. It's easy in the insurance system to do what? Write the prescription because I got how many other people to go see? A bunch. Right. So instead of me saying, yes, you can, we took care of all your big problems. This is something small. Here's a refill. Your other doctor already put you on it. Let's just go ahead and keep it going. I don't think that's the way you need to do that. Because if you know what you know, and that prostate screening has not been done, he's going to have a problem. It's misdiagnosed. You just keep medicating him and doom, he's going to have a problem that, again, as you said, the mortality rate is going to take him to a whole nother level.
Yeah.
Because he's a black male that often is not, that a black male that's not getting screened appropriately.
Well, you saved that dude's life.
Mm-hmm. I'd like to think I did in a way that the screening allowed him to get the care he needed.
Yep.
But if you did not get that diagnosis on the front end, he could have easily had a lot shorter time span in terms of his mortality, right? That could have been something that's a lot greater, but he also could have had a problem where he's literally going and just thinking, well, the medicine's not working, let me get a bigger dose.
Yeah.
The medicine's not working, let me switch to something else. The medicine's not working, well, let me take 2 medicines.
Sure.
And it's not the medicine, it's something else. So fixing the problem is often going to be more important than fixing the symptoms, okay? So any thoughts on the symptoms we talked about? Any thoughts on anything else that we talked about that you would say, hey man, I didn't really think about it, but this has actually come up, or these are conversations that I think men need to know? Anything that you would say symptom-wise? Because again, we know about age, we know about race, but symptoms I think are a huge thing that we need to talk about.
Yeah, and it's a lot of things. Number one, I guess it's good that erectile dysfunction is a symptom because that's something that'll be pretty alarming in most people, right?
100%.
You might deal with some of this other stuff, but I know most people probably call 911 if they realize that that's not working, right? So that, I guess that's a blessing and a curse, right? Also, some of these urinary symptoms, I feel like people can make an excuse saying that it's of old age, or I'm just slowing down or whatever like that, and that's ignorant.
Yeah.
Like you should, the older you get, the more you should be wanting to check things out.
Yeah.
Because I want to extend my life. I was always told it's better to be seen than viewed. So that's where I'm at in life right now too. Yeah. I'm trying to extend that.
But I think you said it so smoothly that people don't understand what that means. So say it a little bit differently, if you don't mind, for the people who might have missed it. It might have went over their head, or they might have basically been in the back and they wasn't listening really closely.
So the term "I'd rather be seen than viewed" means that if I'm walking around, you can see me. If I'm in the coffin, you come and view me.
There you go.
You know, so I rather any day above ground is a good day. So I would say,
there you go.
Do what you need to do to extend your life.
And I always remember a story because you always have these one-liners when you were at the gas station with this lady.
Oh yeah.
See, look, I didn't even
Yeah. I remember that story.
Go ahead and tell the people what you told them, because the scene in view brings me to exactly that story that I always remember that you said. That always makes me laugh, but it also highlights how your viewpoint can really hopefully change people's perspective.
So, and you know, the lady laughed and whatever. So, if you've ever been to Costco and put gas, so Costco has these gas lines where you can only go in one direction, where you can pull the hose on the other side of the vehicle. Mm-hmm. So if
it doesn't matter what side.
It doesn't matter what side your tank is on. So if your tank is opposite from the gas pump, you can pull it over and put gas, and it'll extend to where it's long enough to where you can do that, right? So I pull up to Costco in New Orleans. I'm living in New Orleans at the time, and I see this older couple, and they seem to be struggling with the hose. So I go help them, and I pull it over and put it in the tank for them, right? So this lady's like, "Well, thank you, young man. You know, you're going to get old one day too." She was like, "Well, you know," I told her, I said, "Well, ma'am, I look forward to it." She was like, "Well, no, you don't." I said, "Ma'am, getting old beats the alternative. I look forward to being an old man one day."
There you go. Absolutely. And at this point, as you said, rather be seen than viewed. It's kind of the same thing, right?
Yeah, I look forward to being an old man, bro. Like, I'm going to be, like I said last episode, bro, I'm going to be the old cat in the chapter meeting. I'm going to be 117.
I like it. Are you going to be the get off my lawn old man? Or are you going to be the old man that like has all the kids coming to the house and you actually trying to school them about back in the day?
No, I'm going to be the get off my lawn old man.
I can see that.
Now, I'll have people at the house. I still plan on grilling and doing that type of stuff. But yeah, don't mess with my grass. I'm almost like that now. Like, don't, you know.
I can tell. You seem really, really bothered about this grass.
No, you know what really grinds my gears?
What's that?
When somebody doesn't have their animal on a leash or something, and the animal's just like on your property. And it's like, I don't have any pets. Why is there an animal on my property? You know, like, it's really irritating.
I see that.
And it's been irritating since my mid-30s. So
I see that.
At 80, 90 something years old, it's going to be really irritating.
It's going to be a lot more irritating. I can see that. And definitely annoying enough for you to literally be the get off my lawn person.
Oh, I'm gonna absolutely be the get off my, but I'm going to be a nice old man. I'm going to be a nice old man with like certain quirks. And the grass is one of them.
Grass is a quirk. Okay. I'm not going to say that I'll venture too far from that. I'm just going to have a fence. I just think about it like that.
Oh yeah, I mean, but you can't fence the whole yard.
I'm trying to fortress this thing. That's what
you have a moat.
Moat everything, right?
when I come visit you, you got to let down a drawbridge.
Absolutely. I'm going old school. The Jasper Castle is what we call it. Okay. So back to the episode.
Have some whiskey in that thing, boy. We'd be good. Some bourbon in there.
There you go. Yeah. Drawbridge whiskey. I like it. Yeah. All right. So we're going into screening recommendations. So we talked about symptoms. We talked about the age that you should hopefully be screened because certain ages have more prevalence than others. We talked about the mortality for those racial demographics. We talked about symptoms. So again, there are more symptoms, but we hit the high ones. So these are the things that I think are probably the most important. And now we're going into screening, right? Mm-hmm. So who should be screened? When should they be screened? Some of this you already know because we already talked about different demographics that have higher prevalence, higher incidence, higher mortality rates. But the screening recommendations are pretty straightforward for most people. So usually when you get to age 50, you should be screened, usually. So across the board, pretty much all men should start getting screened for prostate cancer around age 50. However, if you are in a higher incidence category, higher prevalence, higher incidence. You should start screening earlier. So most men who are in the higher incidence category should start screening around age 45. Okay? Most men, age 45, in the higher incidence category. Now, the very high risk category should be screened at age 40.
So what's a very high risk category?
Well, I'm glad you asked, my friend. So very high risk category are people who tend to have extremely high levels of prostate cancer in their family, or they have extremely high risk factors of other things. Smokers, extreme alcohol consumption or alcoholism, plus the family history, right? And family history is usually things like having a first degree relative in your family who are potentially survivors of prostate cancer or diagnosed with prostate cancer. So first degree relatives are people like your brother, your child, your father, and potentially grandparent if you want to count that, but not necessarily things like your uncle. Now, it's not saying the uncle doesn't count overall, but first degree kind of ramps you up into a higher category. And if you have a first degree relative with a prostate cancer diagnosis, you have a huge risk factor, and that risk factor now puts you in a higher category of when to be screened, right? So again, that's why you'll hear me say, well, do you have a family history of prostate cancer? If so, we're going to screen you a lot earlier compared to you don't. Or do you have symptoms? Or do you have things like you said, you are a smoker, or you are someone who drinks plenty of alcohol, and you may not smoke all the time, but you smoke here and there. So those things start to all add up into this very nice, let's use Louisiana term, gumbo of when to screen.
Right.
Okay. So that's something huge. So again, family history, lifestyles, right? The other lifestyle that I think is important in terms of screening, if you have someone who's extremely obese and extremely sedentary, they have a higher risk of prostate cancer. So believe it or not, getting up and moving helps to lower your risk of cancer. And people don't think that. Well, why should I exercise? Well, I'm trying to lose weight and I'm trying to lower blood pressure, all that. What if it helps you not have cancer? Like, it really is not just, well, we're trying to get you to fit into this fill in the blank. It really comes down to we're trying to keep you healthy.
So, dumb question.
Yes.
How does exercising help you not have cancer?
Well, I think, again, you're eliminating a lot of bad behavior as a simple concept, right? Usually if you're exercising, working out, you're not eating as many bad foods because you're doing that with a health focus. You're also not having bad behavior all the time where you're literally only sedentary. You're only eating bad foods. You're only smoking and drinking and doing things that are going to put these, for lack of a better term, toxic things into the body in excess. So the exercise tends to change the trajectory by helping to have the heart pumping better. And if the heart's pumping better and pumping positive things into the body, around the body, and throughout the body, it's going to probably be less likely to pump bad things because you're doing this often, if that makes sense, right? So let's imagine you take medicine and you're working out. The heart is pumping stronger and faster, so now the medicine is pumping through the body stronger and faster, so it can get to places that it probably otherwise wouldn't have got to, right? And why? Because again, if the blood flow can't get all the way down to the leg because you don't get up and move around and you have very narrow blood vessels that are now being constricted, when you start working out and those blood vessels start to open up and circulation is better, you now have a healthier leg. Makes sense there, right? Same thing for your prostate, right? If your prostate is now having more blood flow that allows it to not have negative stuff go to it, sit in it, and never leave, you're going to probably have a healthier overall
I got you.
likelihood.
Makes sense.
Hopefully that makes sense.
No, that makes sense. I guess I've never really considered it like that.
Yeah, well, blood flow is a huge thing about health, right?
Right.
So the more exercise you're doing, and let me caveat to exercise, if you're a patient of mine and you're listening, you've heard this before. So you're welcome because you hear me say it all the time. You can go work out all you want and have the most amazing looking muscles, and then your heart is still trash. And that's why a lot of patients come to me and their cholesterol is high, but they got great muscles. And they're literally like, man, I never thought about that. And I'm like, you got to change your diet.
Yep.
Not only change your diet, we have to get you to do more cardio.
Yep.
It's not about always throwing up a bunch of weight, but then your heart is horrible.
Yep.
Throwing up a bunch of weight, but your blood vessels are constricted and blocked with a bunch of cholesterol. You have to get your circulation going, and that's where the cardio comes in. So that helps your prostate, but it also helps your heart, helps your brain, helps your lungs, helps your kidneys, helps a lot of stuff because circulation is better. And if that highway is open to circulate more good stuff, less bad stuff, we're going to actually live longer. So that's why cardio is huge. And it's not only huge for cardiovascular health, but other health as well.
Yep. So, you said a lot. because
which happens. My bad.
yeah, that's all that school you went to. You know, I feel like I sound like Bobby Boucher, mama.
The funny thing is that you almost sounded like the old man on the grass thing, right?
Yeah.
You think you're smart.
Yeah, you think you're smart. You know, just because you went to 10 years of school don't mean nothing. Got 80 years of life. But yeah, so
I only laugh because that's 80. I hate to see 85, 90.
oh yeah,
It's
I'm
getting worse.
I'm telling you, man. Go outside with my cane gold and my lemonade.
You gonna be a cardigan guy?
Oh nah, I'm not gonna be a cardigan
Okay,
guy.
what do you think?
I'm gonna just like I don't think old people change their clothes. I think they just wear stuff of their time.
Sure.
So we could be old people wearing like Jordans, and you know what I mean, and like t-shirts.
There you go.
They're like that's the kind of old people we about to be.
I like it.
But you said a lot just now, because I don't think people really consider what causes cancer and how their health can help with cancer. I think you hear things like being in the cancer belt or the cancer alley with oil refineries or plants, the things that you're breathing might give you cancer, or maybe like a certain food that you may eat, or drinking the water after it's been sitting in the truck for I don't know how long. Like, I think that is the general the thought process when it comes to cancer.
Yeah.
I don't think we consider, just, you know, as the average, you know, person thinks about how the body works and how it flushes things when you're healthier.
Yeah.
I don't think people consider that. I think people just say, well, they smoke cigarettes their whole life, they got cancer, or they worked 30 years in a plant, they got cancer. I don't think people consider their health when it comes to like a cancer diagnosis.
Yeah, and I think you're spot on, because when people do consider it, you can probably see that their behaviors change.
Yeah.
Right? They're now thinking of themselves holistically and not just thinking of themselves in certain systems, which is how some medical professionals operate. Well, you have an issue with this system, we're going to treat that symptom, we're going to treat that system, which is why, and we'll do this episode another day, we have people who literally end up getting on, they go to urgent care and they get antibiotics, steroids, and usually the third thing could be some other medication like allergy medicine. They give you all three at the same time. There's no rhyme or reason to do all three at the same time. It's just the shotgun approach to quote unquote make you feel better. So you swear that all three of those things made you feel better when really one or maybe two of them were necessary. And by doing that, you don't think any differently of the long-term risk factor, because hey man, I feel better immediately, so
Right.
I'm great. But then down the road,
Yeah.
someone comes and educates you on really how this should be done. You start to change your habits and your behavior, where you don't call and say, I want antibiotics. You call and say, I want to feel better. And if I can get you feeling better and the antibiotics are there when I need them, they're not resistant to where I can't use these antibiotics anymore because now I've used them too much on some BS. So now we're, having to send you to the hospital to get treated for something that should be outpatient. So the health part that we're talking about when it comes to circulation and heart health and all that, this is everything, holistic health, overall health that you can achieve by basically getting up, getting active, and not sitting and waiting till something negative happens.
Yeah, I'm glad we're having this conversation.
Yeah.
Because I saw an advertisement the other day. Subway has foot-long nachos now.
Foot-long nachos with what?
Doritos.
Mm-hmm. Yeah.
And you know what? I was gonna get me a foot-long nachos Doritos. Because
Just don't call me.
I think I'm gonna go get a salad now.
I think you should. Because I don't understand why in anybody's mind they think they need foot-long nachos of any kind. It doesn't have to be Doritos. I'm not saying you can't have some.
Because it's delicious.
Well, again, I'm not saying you can't have some, but a foot-long, that's just excess. That's like if I gave you a foot-long steak.
Well, so the foot-long steak, right? How thick is the foot-long steak? Because that the foot-long steak might only be an inch wide. That's a 8-10 ounce steak.
And you okay?
Now if it's a foot squared, It might be difficult to put down.
It might be. Now, my question is, what if we covered it with cheese, jalapenos, and all the other stuff that comes on these nachos?
The nachos. Okay, I thought you were
No, I'm
talking
talking
about
about
the
the
steak.
steak.
I'm about to say, man, all I need is that gorgonzola garlic butter.
And I just hear your cholesterol going up as you talk.
Hey, my cholesterol lower than the scale, player. I need some of that gorgonzola garlic butter, man,
You gotta
because
raise it a little
I gotta raise my cholesterol a little bit.
Well, I say all that to say,
I'm healthy.
Going back to the episode, you're welcome, by the way.
Appreciate it.
Yeah. Going back to the episode, so about the prostate cancer, the last part we're going to talk about, and then we'll close out, is that today, if you're listening to this, you will hear us say with confidence that there is not a reason not to get screened, because the main reason people tend to not get screened is they don't know when to get screened, they don't know what symptoms to look out for, they don't know what risk factors are most prominent, but more importantly, they don't know what type of screenings are available. So there are two screenings that for the most part are going to be available. The one that everybody for the most part knows and hates is what we call a DRE, a digital rectal exam, which is a fancy way of saying someone takes a finger, inserts it into the rectum to feel the prostate. That is the older way.
Oh.
That is the older way of getting screened.
Like, I was like digital,
Yeah.
but like finger digit.
Finger digit, yeah, not the number 7 or 3.
Yeah, I was.
No. So digital rectal exam is the way that most people who are anti getting their prostate checked because they don't want to deal with that don't get checked. The way that we have been taught to actually screen with newer medicine, newer medical techniques, is instead of doing a rectal exam, or DRE as we call it, we do a PSA. A PSA is a prostate specific antigen test. It's a blood test. And what we do is draw blood like we do for everything else, your cholesterol, your thyroid, your kidney function. We do a prostate test on your blood, and if that number is pretty much normal, that's it. We don't do anything more. That's literally it. If the numbers are normal, you don't have symptoms, you don't have risk factors, even if you're in the range from a 50 to 75, if your numbers are normal, we usually don't have to do much else. But if your numbers are abnormal, then we move to other stuff. The problem is most men don't get any of this done because they think, well, I don't want to get this rectal exam, so I'm not dealing with it. I'm not going to talk about it. I'm never going to get checked.
So, question.
What you got?
Because although I don't want to be viewed, right, I'd also like to avoid this finger.
Yeah.
So, this prostate-specific antigen test,
PSA, yes.
PSA, how accurate is it compared to the finger? Is it just as accurate?
Mm-hmm.
Or, like what is the disadvantage or advantage? Or it's just new technology? Welcome to 2025.
Well, I'll say when it comes to accuracy with screening, the way screenings work are meant to capture more things, and then you go and you narrow down how accurate it is. You want a screening test that's broad, and then you want a diagnostic test that's specific. That's how they teach you in medical school. So a screening test, you don't want it to be too narrow, because if it's too narrow, you're going to miss people. And when you miss people, that's when people get misdiagnosed that they don't have cancer when they really do, which is a problem. So you'd rather have a screening test be very broad. That's what these tests are. The screening test, the PSA, is not meant to be extremely pinpoint. It's meant to be broad so we capture more people. If that test is slightly abnormal and you're like, well, it gave me a false positive where it looks like something's wrong, but it's not. That's okay, because we'd rather overdiagnose that you have something and then do a diagnostic test that tells us we overdiagnosed and we were inaccurate than we didn't. We were really narrow. We missed you because you were on the outside of the screening test, and then you really did have something. Does that make sense?
Yep.
So that's the whole idea. So to answer your question as directly as I can, the PSA is not in itself the only test that's going to be the most accurate overall. It is meant to be very broad. It's meant to not be the most accurate to capture more people because it's a screening test. From there, if the screening test is abnormal, then you go into more specific tests.
I guess my question was, in relation, like, thank you for explaining that, because so basically what you're saying is the PSA is broad, and based on what the results say of the PSA, then you go further and do something else.
Absolutely.
So I totally get that.
Yeah.
So compared to the more antiquated test, the digit test,
DRE.
how is there any advantage over from one or the other than like just discomfort?
Yeah, it's pretty much discomfort. That's pretty much it. And I'll say this.
So I can avoid this digitest with this PSA and be fine.
To an extent. So to be as clear, so there's no misconception, if the PSA is abnormal, we then move to a rectal exam. Because we don't want to go, well, look, this is the alternative. We don't do a rectal exam, then we have to go in and do what we call a biopsy.
Oh.
So that's your gap. We do a blood test, the blood test is abnormal. You don't want to get a rectal exam, so then we biopsy. If the biopsy is done, biopsies cause more problems sometimes, where you start to have other symptoms like erectile issues, urinary issues, because we're biopsying a organ in the body that doesn't want to be biopsied if you don't need to. So I'd rather do your PSA, and again, I'm going to say it as honestly as I can. I've said this to plenty of people. I don't wake up in the morning saying, I can't wait to do these rectal exams. I don't know any doctor who does. Now, there may be some out there who they like doing them because they're really good at them, or they like doing them because that's what their calling was. That ain't me. Now, I will do them because I want to keep you alive, but I'm not over here signing up waking up in the morning excited. And why am I saying that? Most doctors ain't looking forward to doing them for you, but they're doing them because they want to keep you alive. So as much as you hate them, we hate them too. But I'm willing to do that and be uncomfortable with you so we can both achieve the goal of being healthy. And that's where the PSA comes in. The PSA is basically we don't want to do this. We found something that allows us not to do this. But if it is abnormal, we then need to do it. Yeah. And I'll give you a quick example. I had a gentleman who came in after he went to a different primary care doctor. He literally had an abnormal PSA at the primary care doctor. The primary care doctor, for the short version of the story, just told them, we pretty sure you have cancer. Sends him out the door and says, go ahead and schedule an appointment with the urologist. That's the doctor who's basically your prostate doctor, works in that area, right? He literally calls me, leaving from that doctor, and said, the doctor didn't really explain it. I don't know what's wrong, but he told me he thinks it's maybe cancer and I need to see a urologist. And that's it. He's freaking out. He comes in, I spend an hour with him in the model, literally walk through all of the stuff it could be. It could be more than cancer. It could be something called prostatitis, which is just inflammation of the prostate. It could be a bunch of stuff. But do all this stuff, let's start you on some medicine, and let's recheck it and see if it comes down. You're still going to go see the urologist, but let's recheck it. On that day, I did not do a rectal exam, even though he had an abnormal PSA, because he had already had one. So me doing one and somebody else, that doesn't make sense. So at that point, I said, well, why don't we just try to talk about symptoms, risk factors, things like that. He didn't have a family history of prostate cancer. His people had prostate issues, but not prostate cancer. He wasn't a smoker. Sure. Doesn't drink a lot of alcohol. He works out 6-7 times a week. Very healthy guy. And all that being said, after we treated him, he had an enlarged prostate. That's it. It wasn't cancer. And I was able to calm him down, get him in to see the urologist, and get him feeling better before he saw the urologist, not only from I don't think you have cancer, but also let me go ahead and treat you based on what I think it is, which is an enlarged prostate. Because we went through all of the things that it could be. His risk factors were so low, and he had enough reasoning to basically, in essence, feel like what I'm telling him is a lot more likely than just, oh, your PSA is high, you got cancer, and that's what we think it is. So you have to know these tools in a way that allows you to get the treatment and the diagnosis correct. You can't just say PSA is high, you got cancer. Right. But people do that. People do that because they don't know what they're doing, or they really and truthfully think it's just easy that if the numbers are abnormal, that must mean you got this. That's not how it works. The PSA is a screening tool, and then you have to have diagnostic tools that follow, or confirmatory tools that follow. If you don't do that, then you're doing it wrong. And that's why this is so important to know when to screen, who to screen, how to screen, what symptoms, what risk factors, and put it all together. Because if you don't, you're just doing stuff. Sure. You're doing a piss poor job, and the piss poor job is going to make sure it's going to hurt somebody, because you're now telling someone they need to go get a biopsy when they really don't. And that's not true. And I'm going to give you a little nugget. And this is the last nugget that I think I'm going to give, because I think we done dropped enough gems today. The last nugget is that what can elevate a prostate that would make it high enough that it sounds like a cancer when it's not? Well, it depends on when you check the actual blood test. If a person was sexually active soon before the prostate number is checked, it can give a false elevation. And guess what happened to this guy? He was sexually active the day before that doctor checked him, and that's why it was so high. And the doctor didn't bother to say, well, let me check you again to make sure this is a true elevation. He told him it was high. You need to see a urologist. I think it's cancer. I checked him that day, talked him off a ledge, told him to keep the urology appointment, but come back in a week after we start medicine and let's see, and it dropped drastically. It's learning how to do this and do it so well that people don't have to worry, and you're not sending them through a bunch of testing and procedures that are going to make them feel really sick because you don't know what you're doing.
Right.
You have to be very careful and know how to actually wield these tools. And if we do that, we're doing something right. And I think we're doing something right at the Byja Radio Show because, again, I don't think anybody's ever had a long conversation about prostates like this unless they're in certain offices or they've had certain diagnoses.
Correct.
And they got this for free 99, man. So I think we're doing something really amazing.
Yeah.
So
I agree.
I think today's episode highlights that if the President of the United States or former President of the United States is in a category where it can happen to them, even with probably an abundance of resources, it can happen to many of us. So we need to be in care regularly. And we need to know that we're in care with the right people who are going to give the right information and do things the right way, not just haphazardly because there's a blood test, I click the number, it's up, okay, you got this. Or, hey, I'm not going to check you at all because you're not in this category, or you're in the category, but I don't really know what I'm doing. You have to find the right people to give you the right care. And if you can do that, you'll live healthier, happier, longer life. So I think that's it, man. I think we've covered it a lot. And I don't know, am I missing anything, Patient Zero, or anything that you say, yeah, man, I think this is something that people need to know? Questions that came to mind, or no, you think we hit it, we covered it all pretty thoroughly?
Now, I think we hit it on the head, brother. I think, when you consider some of these symptoms and some of these demographics when it comes to prostate cancer, those things are very, very alarming, right? So I say the PSA, not the test, but the PSA would be to get checked out.
There you go.
Because I would rather know that I'm straight than not know that I'm not.
There you go.
You know what I mean?
And I think the other part for me is that there was a wise statement that was made, and it's a extremely popular book. It's called Spider-Man. With great power comes great responsibility. Uncle Ben said that. Uncle Ben died, and it was very tragic, but Uncle Ben taught Peter Parker that you have to understand that if you're sitting in the seat of caring for patients, you got to basically know what you're doing, but do it in a way where people can really and truthfully learn and get better care. Not just doing some,
Sure.
hey, I'm a doctor, listen to me because I said so, right? So I take that responsibility very seriously, my friend.
Because when you start talking about Uncle Ben, I'm like, they took him off the box because I'm thinking about rice.
Of course you are. Which also goes along with what is the foot-long Doritos.
Maybe I'm hungry.
Easily. So not that Uncle Ben, Peter Parker Uncle Ben. And again,
Peter's a great name, by the way.
It is. Hence why you never seeing Spider-Man is a travesty. So we have work to do, obviously.
You know what? I wasn't really a big superhero guy. Outside of like Christopher Nolan's Batman series, like The Dark Knight, I haven't seen too many superhero movies.
Okay, I'm gonna throw it out there just in case. Greatest Joker.
The greatest Joker.
I'm sorry, top three. Let's do top three.
Top three. Heath Ledger, man. Heath Ledger was, he embodied the Joker. Like it was crazy. Two, I gotta go Jack, man. Jack Nicklaus. Jack Nicholson. I get him confused. Jack Nicholson, right? Because Jack Nicklaus was the golfer, so Jack Nicholson is the Joker.
Which is also embarrassing because you play golf.
Bro, it's they got the same name, man. It's I get them confused. Like I know who both of them are. It's just that I don't remember who's son and who's not. So that's the thing.
Who's older?
That they both pretty old to me. Because Jack was at the Lakers game before Magic got there, bro. Like, that's a long time. But anyway, and then the new Joker is my third one.
I'm pretty sure the son is the younger one. That's how.
Jack Nicholson. Oh, that makes sense.
You're welcome.
That's an easy way to remember. But God, well, that means Jack Nicklaus is old as hell. Because
I think you made your point. What was number three?
The new Joker. I forgot his name, but he's good. Like the one that they made the Joker movie for. The one that the star of that one. He was really
Phoenix,
good.
What's his name?
God.
Joaquin Phoenix.
He
Joaquin Phoenix.
he was so good.
Yeah.
You know, I really believe this character, and in that movie was well written as well.
Very much so.
So you know, character development's on point. He embodied it. He was great. So that's my top 3 Jokers.
I will strongly agree with you. I will interchange Jack with Heath for 2 reasons. Depends on what kind of mood I'm in. If I'm in a more serious, dark mood, Heath Ledger.
Oh, 1,000%.
If I'm in a happy mood, comical mood, Jack all day. That one of the funniest Jokers, which again I think people miss on the idea that the Joker is supposed to be funny and dark, and I don't think Heath was as funny, and Joaquin Phoenix not really funny.
No.
Like they're
Just
funny,
super dark.
but the Joker is supposed to be a little bit of both, right? So that's why I think Jack kills it, depending on the type of Joker. Because if you're wanting comedy, some of the lines that I always remember, where does he get those wonderful toys? That is always one of the best lines of Joker, because to me it was delivered at a perfect moment, but it's also funny, right? Because clearly it's not a toy, but that's how he sees it, because he's a Joker. And then of course Heath Ledger, one of my favorite lines from The Dark Knight, from Heath Ledger is, if you do something well, never do it for free.
Facts. He said that.
And it's something I always remember, because at this point, that's pretty much the idea that you can find information and you can learn from any situation. You just have to have your ears open and your mind ready to receive. And if you can do that, you can literally learn. And when we went to dinner the other night, as we are sitting at dinner, I literally told you one of my favorite Beyonce lines. And I'm not going to say it, because whenever I said it at dinner, you were like, that is a good line, right? But it is in the song Savage. That's all I'm going to say, okay? And it's about price. That's all I'm going to say. With that, it really tells us that you can learn from anything and take something from anything.
You got to say a line.
No, I cannot. It's profanity.
Oh, okay. This is a family show.
Yes, it is. It is.
Because you know, it didn't narrow it down for me, because I don't really listen to Beyonce, so I have no idea what this line is.
Well, if you want to,
you got to tell me after off air.
Well, of course I'll tell you, because I've said it before. But if anybody who's a listener wants to know the line, you can definitely reach out to us, because I have no problem telling you off the air. But for the show, we're going to keep it clean. With that, we're going to slowly close out, because I think we went pretty long on this.
Yeah,
one.
we did.
So if you've listened this long, you're a real one. If you're listening this long, please make sure you like, subscribe, share, and follow. And leave comments that can tell us, number one, how amazing we are, or any questions you have. Anything that can help you in your learning, in your education, we're here for it. That's what we're here for. Clearly, we want you to learn about health, but we also want you to learn what it means to be seen and not to be viewed. That's what we're here for.
Yes, sir.
We're trying to teach life lessons overall.
Yep.
So
we're trying to keep you alive.
With that, Patient Zero, where can the people find you?
On X at George_Becnel, on LinkedIn at George Becnel II, and on Instagram at Becnel Media.
And you can find us at www.byja.org for Byja Clinic, www.byjaca.org for Byja Charitable Alliance. And you can also find us on social media on Facebook and Instagram at Byja Clinic, all one word. And we're also on LinkedIn at Byja Clinic. With that, we will slowly but surely close out this episode. We appreciate you listening to us on episode 31, an amazing episode, I would say. And we hope that you will continue listening. Patient Zero, we got 2 more episodes, and then season 3 will be a wrap, man. Time flies when you're having fun, I'm assuming.
Yes, sir. Three seasons, and we hadn't got canceled. I mean, you know.
And we got some sponsorship, so I think we're doing something.
Yeah, we're doing something right.
Let's
See how far we can go.
Let's go. All right, y'all. Thank y'all for listening. We'll see you all next week.